Then we have the maternity, the neonatal and child health services. I will expound on that. We have the renal care services package. Then we also have the mental wellness, where if you have a mental condition, then that is also undertaken within the medical admission. But there are some which are under the drug and substance abuse. So in the drug abuse, somebody needs to be rehabilitated. There is a program that they will tell you you have to undergo for you to be rehabilitated out of the substance abuse. That one has also been packaged. There is the common surgical services package, which is known by most. Even there, the authority has put the surgeries into classes, into classifications as guided by the Medical Council, and tariffed them. So each surgery has a tariff. So a particular surgical procedure is a particular tariff that the authority undertakes. Then there is also the overseas treatment. When you are referred overseas, the authority comes, the facility has to be one that is contracted by the authority, and then the condition that you are being referred to for overseas is among the list that has been shared by the benefits panel. That these conditions, the interventions are not readily available in Kenya, and so we come in. The tariff that is applicable there is $500,000. So looking deeper into, I had said I'll come back to 4 packages. So I'd look at maternity. Recently, we Waziri or the Kenya government Ministry of Health enhancing 4 packages. I'll speak about them, and then I'll take my leave for your questions. The first one is maternity. In the maternity, there was enhancement. As at that day that it was being announced, we had financed 1.08 million deliveries. In oncology, which was also enhanced, we had 4,661 Kenyans accessing care at that time, and I'm sure they are. In renal care, in our database, we have 43,000. 14,018. So, all this, when you conglomerate in the maternity package, the authority had undertaken which were full deliveries, 27% of them being cesarean, and 1.08 million being safe deliveries. So what the authority has enhanced in this package is the normal delivery. That one is there. We now also undertake the obstetric. We can postnatal care 6 weeks after delivery, and also we look at the newborn. So that then enhanced the maternity package. So remember, if you go to a level 2 or 3 or 4 or 5 or 6, the entire scope of the maternity package is covered. In level 2 and 3, it will be paid under the primary health care fund, and these other ones, it will be paid under the social health insurance fund. If the implications of emergencies, then the emergency chronic and critical fund kicks in. So we can safely say that the government has now guaranteed or free delivery. It spans across the 6 levels of care, at primary level and at secondary level. Has seen that this country safe delivery services regardless of your financial state. It has in essence eliminated out-of-pocket expenditure for the level 2 and 3. and extended coverage even to the underserved in the rural communities. The next one, that the eligibility, how you register and everything, my colleague had spoken about, is the cancer care package. It is enough to be given a diagnosis of cancer. Even as we speak today, I am sure somewhere, someone has just been given that diagnosis this morning or maybe this afternoon. The diagnosis itself is devastating. And we have done our best to see to it that it is covered. When SHA began, there were hitches, but now it has been enhanced. You have all heard, it started at 400,000 Kenya shillings per annum, then it went to 550,000, and now it is at 800,000. So what do we need to do? We need to ensure that this amount goes with the patient as far as it can, or it should. And the authority has gone into working towards clinical guidelines and protocols so that every and any medication you are given is in line with the particular type of cancer and the costs are reasonable. So we have worked together with we have now embedded the National Cancer Care Protocols and the differentiated care models to ensure that whatever is being billed against your allocation does not finish it immediately. Because we had enough experiences of someone going to a healthcare provider and 4 visits, the 400,000 is gone. Every visit, the hospital was charging 100,000. So now the government has come in, we have sat down and we've looked at those protocols and given the correct allocation to them. So at 800,000, we are expecting an improved quality of care, better cost containment, protocol-driven care, and not just a blanket amount to our exposed member. So the same oncology package. So what was new? In the initial, we trusted what the hospitals would bill, but the trends in our database showed us a different thing. The costs were exuberant, and nobody was going to manage it, regardless of how much you're going to put. So it was time we controlled what comes in. So now we have a protocol-driven and active cancer treatment with the 800,000. It has now enabled us to be able to walk into recovery. There's a period of time after cancer treatment, you are a person is declared on remission, and then they do follow-ups and monitoring. They're now able to finance recovery. We are also now able to manage the symptoms, so the supportive care of the side effects that come with the medication. Remember, the mental health is also affected, not only for the patient and even for the caregivers, the family. So that access has been added to the oncology package. I will excuse you for not clapping because I understood you when I stood up here. Yes, thank you. Then we are also able to now finance long-term outcomes with this 800 and this new package that we are now managing to control. So for the visits that an oncology patient may require, when they're on remission, they're told, come after 3 months, we do a blood check. Come after 6 months, we do a PET scan. Come after this period of time, we undertake a following an investigation. So the authority is able to try and finance part of it, part of the visits on an annual basis, and even the supportive care on an annual basis. And then the imaging, it is enhanced for someone who has to access oncology package. So there is an added MRI, added CT scan for these people, and PET scan and for the people who have cancer. So even as they access, there is still some allocation for the family and it is not depleted just because one member within the family is undergoing oncology care. So the sessions for the CT scans, the sessions for the PET scans have also been increased. The SBRT has been increased from 3 sessions to 5 sessions per year to cover for stereotactic body radiation therapy, to undertake precision oncology when we are doing the imaging. The patients who must access brachytherapy now also have a 3rd session in the oncology care. And all this is within the enhancement. For me, that was really good news because we experience these patients in our offices every day. So that was well done. Then another thing that was enhanced is the renal care services. We all know when your kidneys fail and they need to be supported, the authority is now able to undertake that support, transplant, your donor, and any chronic renal care that you might need. So this one is unique because without dialysis, a patient who has kidney failure has a poor prognosis. So since October and up to that time we were enhancing, the authority had incurred a cost of 7.3 billion in claims payments as regards dialysis only. And if you look at the dialysis package, it comes to everything, if you total it up, the services we are financing, comes to 1.1 million. Certainly, that is a care that confirms that the government is standing in support with Kenyans who really need this critical care. So in dialysis, we have hemodialysis and we have the hemodiafiltration. All of them we pay the same amount at 10,650 per session for 2 sessions per week. Then we are also into the peritoneal dialysis. That one we also cover. It could be home-based, it could be flexible, the patient can manage it themselves. Where there is it's ideal for especially maybe the young, the elderly, or someone who needs the care back at home and might not need to use the machine in a healthcare setup. So that's the 2 services that are there. Then when you have to get a transplant, the authority undertakes up to 168,000 for the donor, and then for renal replacement, people who have been transplanted require therapy every month so that the organ is not rejected at 200,000 per household per year. So these were never there. The recipient, we also undertake the surgical procedure at 700,000. And then before all this, there are those evaluation tests that are done. The authority also undertakes the costs at 150,000. The medical imaging was also enhanced in tandem with the cancer care package. And one additional one for a person undergoing oncology, so that if there may be an allocated 2 or 3 per family, then they have their extra one, so they are not depleted. So I will wish to stop there because with my colleague we agreed we just want to hear from you because ground and inasema ukweli, answer your questions, interact with you. Professor tuache kwanza, because this is what we have implemented. But we want to hear from you what is going on in the ground, to understand your questions and to respond so that we are able to be clear on the Social Health Authority and what it offers and how it operates. Thank you.
All right. Thank you so much, Julia. Can we appreciate them with a better round of applause? Because they're here today to answer all your questions as far as the authority, what they do, and some of the concerns that you have. So by show of hands, who has a question? Okay, see 2 hands here. Okay, all right. So please start with your name and please keep your question short and straight to the point, and let us know who you're directing your question to so that we allow as many people to ask their questions.
Good afternoon. My name is Saitwa Saitoti. I'm a founder of a foundation called Autoimmune Diseases Support Group, which I formed after my daughter got a diagnosis for something called polymyositis. Autoimmune is where the body attacks itself, like the healthy cells start fighting and they start making you lose balance, not walk, and all those. So some of the autoimmune diseases I'm talking about are rheumatoid arthritis, lupus, type 1 diabetes, multiple sclerosis, Hashimoto's, hyperthyroidism. Then myositis is quite a number, myasthenia gravis, and so many. Most of them present with chronic fatigue, which is deep persistent tiredness, joint pain, swelling or inflammation, skin problems, digestive issues, brain fog, and fever or general malaise. So, my question is to Julia Owino. I've not heard you talk about this chronic illness, because autoimmune disease are chronic illness. There's no cure. I had to take 1 year to get a diagnosis for my daughter. And I did that after I got tired of going to hospitals here in Kenya. I went to almost all hospitals in Nairobi, and most of them were not getting any reports. These things are very expensive. You need imaging. You need to do an EMG, CRP, MRI, CT scan, biopsies, spinal taps, and so many others. So, all this time, we are seeing neurologists and all these specialists. One consultation costs between 3,000 to 10,000. There's one rheumatologist which actually charged 23,000 per consultation. There's a day I paid around 120, just one day, for doing tests, ANA tests. All this time, 2 years down the line, SHA only covered 8,000. And I ended up using almost 4 million for her to get the treatment she required. And we got that in India because I had given up. At this point, my daughter had lost her ability to walk. She was in a wheelchair. So, right now, I'm representing other patients because my daughter got stem cell therapy and bone marrow transplant in India, and she was able to walk. I've just seen Nairobi West Hospital are offering the same service. It's maybe a bit new because I didn't see that before I went to India. There are patients I have who are in some hospital like KNH and others who are claiming they are not able to get the medication they require. One of the medication is IVIG infusion, which is needed by people with autoimmune diseases. There is rituximab and methotrexate. This medication, just one, is between 70 to 100K, just getting that infusion. And the places that are available, they are saying they're only giving it to cancer patients. So it leaves me wondering, is it that people don't know about autoimmune patients? Do you know these are chronic illness? Or why aren't we being given priority? Because everywhere, everyone is having issues. And even the doctors insist we have psychological issues because they don't know these diseases. So how can you help us? How can you help us? Because I think in a month I spend between 60 or more just to get medication. And for some others, they use more, much more. We need special diets, we need supplements every day. And flares can come any other time. You could be okay tomorrow, today you're not doing okay. So to Julia Owino, kindly tell us, where are we in that list? Because I didn't hear you mention us. Thank you.
Good afternoon. My name is Peter Kairanga, and I have two chronic diseases. One is a heart disease called tricuspid valve replacement. I need to have it done in India. Kenyatta was not able to do it, and Shah said they have nothing to do with any coverage about people who are going to abroad. So my question is, if people are not able to do it in Kenya, just a bit of help from the government for people who are going to abroad and they have no choice. The second one is when I went to India, because I went for a bit and then my money ran out, so I had to come back. And I'm back since 2 months ago. I was given 1.5 months to raise money and have my surgery. Now, the other thing is, I've just come from dialysis at Upper Hill, and I was told to have dialysis 3 times a week, and Shah covers twice. For a person who is not able to raise money to even get medicine and everything, because a lot of the money that I used to go to India was from Harambes. I am an electrician. I don't know how many electricians would be able to raise 2.5 or 3 million shillings to go to India just for the heart surgery first, then the kidney surgery later. Now, I was wondering what you guys are going to help us with, or me rather, because I'm the one who's. And I would give you something else. It's not about complaining every time about the government, about the services and everything. If you Google my name, you'd see I'm the oldest surviving open heart surgery patient here. So it means I will have good doctors and we have good services at times. But this one's, you really let us down. Thank you.
Sorry. Hello, my name is Grace. I just had 2 questions. The patient who has raised issues about dialysis, initially there were 3 sessions that were being covered by the government. So I'm wondering about NHIF was covering all of them, and they didn't have to go back to their pockets. So when this patient is added a 3rd dialysis, that means they are spending 10,000 every week. In a month, we are spending more than 40,000, and on top of that, there were some tests that they were doing that were being covered by NHIF and drugs. They have been removed from the package, so the patient is going deeper in the pockets to have the tests done, which must be done in order for the dialysis to proceed and take the drugs. My other question is for the cancer patient. You've told us that the amount has been added to 800,000. I have a cancer patient, and I have had to sell some piece of land to be able to continue his treatment. We could not stop it in the middle. And I'm wondering why that when there are 2 people who are contributing, we have decided NHIF initially was covering 500 per contribution. Now you've changed the contribution to be called per household. So in spite of 2 people contributing, a husband and a wife, you're putting them together and giving them 400,000. Initially, it was 1 million. So despite adding the money that you're saying for the chronic patients, you have said that there are some protocols you have put in place. So when these tests are being ordered, because I remember there was a PET scan that was ordered for my husband, and I took a walk to the office and I was told that there are some diagnostic they do not cover. They call it diagnostic. They are only covering for treatment. So you will find yourself being a lot of protocols and a lot of mumble jumble that you're given, and yet you have a patient. Even the way you're saying about the chemotherapy, there are some that it doesn't cover. And also you'll find yourself being given some hospitals, they cover the treatment, another hospital they don't cover. They've told us you are supposed to have 2 MRIs, 2 CT scans, 2 major surgery, 1 minor surgery. Such English, a lot of protocols that we have put in place, yet this patient does not need all those protocols because they are sick. So some of these things I think we should look into, and even that chronic 150,000 that was added, when we tried to access, there's a time they said that there's no money. It has been approved in the public. But when you take a walk to the office, you're told the money is not available. Even now when you tell us the 800 is available, when you walk to the hospitals, we are told the money has not been released. So the patient does not receive the treatment. So here we are told a lot of information, but when you go to the ground, the treatment is not available. So please, the patients out there are suffering, and despite us saying that we've put things in place, the drugs are not there. There's a health center I was walking to. I used to get my consultation free. I'd get some blood tests free, and I'll also get some drugs free. With the SHA now, most of the blood tests, we are paying for them. The drugs are not there, and even the consultation I'm paying. To finish it off, when you say about the maternity, some of these level hospitals you're giving us, the surgeons, there are no surgeons who are there to do those CSs. So when you're referred to another hospital, you'll find yourself paying, especially when there's a complication, and those number of days, because with the new protocols you have put in place, there are specific number of days you're supposed to stay in hospital, and there are specific treatments that are available, the rest you pay cash. So basically SHA is a reduction of the initial NHIF cover, and I'd really like you to state about the husband and the wife being put together, yet each person is contributing.
Good evening. My name is Christine Naoko, a student at Mount Kenya University pursuing health system management, and I'm also a pre-intern clinician. So my first question is, I want to understand how SHA actually calculates contribution, especially for informal workers, because people down here are actually, they feel they're overcharged. Personally, I have a sibling who is suffering from sickle cell anemia, and let me tell you, it's overwhelming. Another question is, what protections exist for unemployed people and even vulnerable citizens who cannot meet the contribution? Then the last question is not actually a question, but I understand most of the people are trying to adjust to this change, and most of us don't have actually the exact information about what SHA is, the benefit, and what actually we are supposed to be benefiting from SHA. So my question is, what are the measures that you've put in place to make sure that the public has information about SHA, what it covers, the referral rules, which hospitals actually are approved for SHA, and what are the measures that you are putting in place to make sure the public actually learn about what SHA is? Thank you.
Hello, my name is Wendy Ekono. I want to ask about autoimmune diseases. I know that Lady Saitwa, and I have one of the conditions that her daughter has. When you live with an autoimmune disease, you don't live with one condition. We have what we call overlap syndrome. So I carry 10 chronic conditions. 7 of them are autoimmune diseases. What I want to ask in particular is this. When you are treated with tablets, it gets to a point when your body cannot haikubali hizo madawa anymore. So you have to advance your treatment, and you're given chemotherapy. But when we come to the chemotherapy part of it, you do not give us chemotherapy the way you give it to cancer patients. All the benefits that you have listed for cancer patients do not apply to us. Sometimes you don't even pay for the bare minimum. I feel that that is very unfair because we are dealing with a lot. Number two, I want to ask about contribution. If someone is an adult, unemployed, and chronically ill, they live in their father's house. But when I come to fill that SHA questionnaire, you're asking me, does the house you live in have a toilet? Does it have stairs? Does it have this? It may have all those things, but you're not considering the fact that I don't have an income. My father is buying my medication every month. He is paying for my medical care. So, sa ile unataka yeye anilipie SHA premium iko juu hivyo. Where is the humanity? Mbona hakuna mahali ya kusema, are you unemployed? Yes. How old are you? Yes. Are you chronically ill? Yes. Zile madawa unanunuliwa zina nini pesa ngapi kwa mwezi? All those factors. Because he is the same person ambaye atalipa hiyo premium. Okay? Na bado mtakataa kunipatia chemotherapy ya kunitibu on this other hand. So when we say it's not working, usikachi kwa sababu hatuisemi ati kwa sababu kusema tu, it's because it's our reality. Yeah. Yo.
Good afternoon. My name is Winnie. So I'll ask questions on reimbursements, majorly because the healthcare sector faces a major challenge of cash flow, which SHA is currently contributing to because of the reimbursement timelines. So as at now, I think it takes 3 to 6 months, about there. To you, what do you think healthcare professionals can do to make this timeline shorter? And what do you think are the factors contributing to these, to the long-term reimbursement timelines? Then I'll also speak to the customer service at your offices. Look into it because it is wanting. I'm in human resources, and the number of complaints I get from staff who are visiting your offices are quite a number. Then there is a bit of mental health, and this is more of a proposal. I know SHA covers mental health. However, there is a risk currently, I think throughout this session, what we've noticed is mental health coming up a lot. There are private insurances that are offering psychological support services on call or virtual, which are free. So this is a proposal to you. Maybe you can include it in SHA so that I am comfortable sending my staff or referring my staff for your on-call or virtual services, psychological support services. Thank you.
Good evening. My name is Imelda. I'm a medical pre-intern and I have 2 questions. So my first question is, you've mentioned packages such as SHA Lipa Pole Pole for unstable income households. You also mentioned the program for teenage mothers that enables them to access prenatal care, delivery services and postnatal care, the programs for orphans and prisoners. So as a medical pre-intern, I've never heard of those services and I believe many Kenyans don't know about them. So my question is, what are you doing to create awareness in the grassroots about those packages, because most people are not aware of them? So my second question is a follow-up on that question. So from the maternal packages services, you mentioned that a person needs to have registered but not necessarily paid to access such services. Right, so that is something I applaud, but most of the hospitals you will find complain of delayed government reimbursement to hospitals after offering such services without receiving payments. So my question is, what is SHA or maybe the government doing to curb that? Then my last personal questions, so I have a relative with epilepsy and they take the drug Keppra, levetiracetam. So most of the time when they try to use their SHA to access that drug, it's either not in the hospital or it's not covered. So I really want to understand that because the drug is really expensive when you buy it outpatient. Thank you.
Thank you. My name is Boniface Mitambo, the National Vice Chair of Kenya Union of Clinical Officers. And I have one question which is more similar to my elder brother there concerning the SHA taking care of the patient who are being referred outside the country. We have a colleague who actually lost her daughter this Monday. He has been in India for the last 2 months. But when he came to SHA, because he's also a civil or public servant, the SHA did not be able to cater for the treatment of our daughter, because the daughter had been diagnosed with Down syndrome and also congenital heart disease. So we had to come as friends and also the family to be able to at least contribute towards that. So I think SHA need to be able to look at to some of this categorization. You see, when someone is sick, he doesn't choose what condition maybe you need to suffer as per the categorization of the protocol of SHA. So I think that is the area that need to be looked at. Then on the other side, I think I just want to ask something that, because when SHA came in place, one of the main aim of SHA and also the NHIF was to be able to ensure that as a country and as a population of this country, we are moving towards the universal health coverage. And when I look at some of the categories of representation of our colleagues from the SHA, I can see also that part of benefits and the claims and also the service providers. And you find most of my colleagues, especially the clinical officers, and I think other cadres, especially maybe away from the medical officers, those who have facilities, they have pending bills. And all these pending bills, when we try to follow up, they have been coming up because we are providing the services, but the SHA is not able to be able to pay the claims, because when you go to the portal, majority of the health service providers, clinical officers, nurses, physiotherapists, their system of the SHA is as if doesn't recognize them. But they are the real people, majorly in the rural areas where they are providing the services. If you look, for example, I'm able to give like our colleagues who usually do the ophthalmology procedures like cataract surgeries and the rest. Majorly in this country, almost 95% are clinical officers. So I think SHA need to look at least so that we can be able to also enhance and promote the availability of health services across the country. Because I had also my sister saying that you go to some facilities and they are not able to be allowed to be able to, as in those procedures they are not available, but the health providers are there. So I think SHA need to be able to look to that, so that at least you can be able to promote at least universal health coverage. Thank you.
Good afternoon. My name is Favorite Ogeto, and I have a few questions. So for the Lipa Pole Pole program, you mentioned, Gilbert, you mentioned that people will need to pay 4 months premiums to be able to qualify for the Lipa Pole Pole. And for a population that lives hand to mouth, don't you think that is unrealistic for them to afford a 4 months payment for them to be able to qualify for the Lipa Pole Pole program? The next question is for the teenage mothers. You mentioned that they receive a 1-year coverage. Is that antenatal or postnatal? And if it is from birth postnatal, what happens when the child stays in newborn ICU for prolonged time? The other question is there, or rather, what is the transition process from SHIF to ECCIF? Is there a clear transition process, and are healthcare providers aware of that process, and also the patients? Thank you.
Thank you very much. Let's take 2 more questions and then we can answer those ones. We have 2 people who have mics and then we'll come to you.
Okay. Mutuku Sharon is my name, and I'm happy to hear about the announcements which Julia has just mentioned. And for me, I'm going to raise concerns from a provider perspective. Because yes, you love a patient as one of the stakeholders, but you also need the facilities to provide the care. And for me, it's in regards to claims payment. And I'm sure this is not a new thing for the 2 of you, or for the authority and all the providers, because I think I'm voicing for all the providers, or most of the providers. And first, it's a concern regarding the payments. The payments are not coming as expected. And I do not want to compare what was there before and what we have right now. But I think something should be done regarding the payments. The other thing is in regards to a category of claims that are currently having the status rejected claims or rejection claims. And a worrying example, it's a very huge number of claims for my facility or the facility that I represent that has a very, huge millions that have been rejected with the reason no claim form. As much as I had my team go through those claims, and the response was, we actually have not only claim form but so many documents as required by SHA attached to this claim during submission. I personally went through each and every claim. That was 2 days plus. And those claims have all these claim forms and other requirements that you guys need. So what could have happened? Like, what really happened for claims to have a decline with a decline reason of no claim form, And remember, when you decline these claims, and you, it means the entity, not you as people. When these claims are declined, that delays the payments. Then what happens to the service or quality of care to patients? Because there is no cash flow, then this will compromise the quality of care, which is not what we represent or what we want for our patients. So what can be done about fastening the payments and dealing with some of these decline reasons that are not correct, that are not true, Because it's a bit worrying in regards to the system and, everyone within the authority. Thank you.
Hello, I'm Faith Nyanchama, and mine is just a concern in regards to maternal health. So my question is, a recent study was recently done, and 30% of gynecological visits were due to infertility cases, and a lot of our mothers are really going through a lot in regards to infertility. But looking at the SHA packages, that is something that has not been captured, and the burden has now shifted from the government facilities to the private facilities, where you get IVF packages is quite expensive for a normal Kenyan. Same to IUI services. So I'm asking, what is the government doing in regards to infertility?
All right, thank you. I know those are many questions, so can we take those ones first, and then we'll do another round of questions. But really, if we give you a mic, please keep it short and straight to the point so that we answer as many questions as possible, because probably this is the only time we'll have the SHA team here.
Thank you, team. They say to whom much is given, much more is expected of them. As my colleague indicated, this is your day. We are here to respond to your questions.
How many questions do you have?
Allow me to start with the questions of proxy means testing. And I've had some people, Imelda and my sister there, raise concern that the amount that is levied for these non-salaried households
deleted them. You cannot use somebody else's. And that is why you hear Grace saying, you can't use, your husband is paying, you're paying, you can't. It is tied to your client registry number, that particular benefit. For the PET scan, probably what could have happened is this member could have exhausted the first 400,000, and that is where PET scan has been placed. The additional 150, the additional 250 to bring it to 800 was taking care of, the additional 150 was taking care of medication, oncology medication. So if you have utilized 400, but you have 550, and you're going for a PET scan, which is 60 or 70,000, it will not process it. Why? Because it has tied the 150 to chemo drugs, not to the investigation, which is the scan. So that is why you could have been told you are not able to be covered. The 800,000 has been implemented unless there is a challenge. Once the government announces it, allocates the money, brings the money to SHA, we roll it over, and that was done. For medication not available, this would go beyond us, but it would be in our great interest. It is in our great interest, because when you show up and they bill us and they didn't give you medicine, then that is not right. So it is the honors of the health ministry to ensure through their policies or the Cancer Care Institute that medications that are specific to cancer are available. Christine, is it, asked about sickle cell, and then many things on public information and registration. Sickle cell is covered to the extent in which the authority can afford. So it is clearly covered. If you access our tariffs, which is a public domain document, the benefits tariffs, you will find sickle cell is covered there. For the autoimmune diseases, we have spoken. Kindly follow up and ensure that the BP TAP has your concerns. For the reimbursements, Winnie, my colleague Soro will speak about. Imelda, Shalipa Polepole, I think you've been understood. Level 2 payments, hospitals not being paid, my colleague will take care of that. The medication for epilepsy, what SHA does, it pulls medication together with the rebates or the outpatient costs. So once it does that, you will find a healthcare provider telling you it's not covered. So these are things we are working with providers to not tell members that it's not covered when it is covered. At times, probably, they could have bought it with some costs, and the amount the authority is willing to pay is not up to it, so they would want you to add more. So those situations are also there. Boniface, I wouldn't want to mention the baby's name, but the authority undertook its liability. We took the baby, we took care of the costs, and we brought back. This is a beneficiary of the public officers. So that was done. So the person was not abandoned. The person was taken care of, including the medical assistant who went with them and was brought back, the caregiver, all that was taken care of. When it comes to not recognizing clinical officers in the system, I would challenge you and the association to bring them up so that they are updated on the database, because these are people who offer services down to the rural areas. They should be able to send a request and it is processed. So when they are not updated in the database, then it becomes difficult. So the onus is on the council and the association, just like the medical council, to bring up their specialities and every other officer who is serving Kenyans specialized services and needs to be activated in the database. Because currently the way the system is, if a medical professional is not activated, when they send a request with their number and their name, it doesn't pass. So kindly help us there, bring it up and bring it up quickly so that people who need services don't fail to get just because the medical profession is not up to date in our database. The other question was on Lipa Polepole. My colleague has done that. Teenage mothers, you've spoken about that. Transition of shift to ECCIF. Emergency illness for your information, the government has taken care of the first 24 hours. So that is tax paid. So when something has happened and you require urgent care, it has been elaborated what the authority is supposed to pay for the first 24 hours. Thereafter, you must have been a SHIF registered and fully paid up member, then it automatically transits you. And even if you are not a SHIF member registered, the first 24 hours, you will access the service. But thereafter, because now it has to bill into SHIF, it transitions you automatically if you are fully paid up. Sharon talked of the claims payments. Infertility, the authority still does not have funds that have matured enough to take care of the public who need in vitro fertilization and infertility costs. But that doesn't stop you from making the benefits panel know that you'd want this also covered as a package. It could be a start. They can just say, okay, for a start, we can only pay for this. That is something than nothing at all. So this can also reach the benefits panel. Get the form from SHE regulations for the SHE, form number 4, get it in the website, Jaza, iwafikie, because the authority implements that benefit package as it is. You have some more? Thank you.
There was a question that was raised by Sharon and I think Winnie on the issue of rejections of claims. We hear you, but allow me just to break it down why claims are rejected. The first reason why claims are rejected is incomplete or partial documentation. Now, sometimes we find discharge summaries or case summaries that are incomplete. The diagnosis is at variance with the discharge summaries notes. The itemized invoice is not itemized. We find a provider just writing a figure of 40,000 and circling it. SHA requires you give a blow-by-blow breakdown of what you are submitting. The other reason why claims are rejected is frequent cancellation or alterations. When you make so many frequent cancellations or alteration in entries you are doing in discharge summaries, in theater notes, it raises red flags, and as such, they'll end up being rejected. The other reason why claims are rejected is because of blurred or ineligible attached documents. Remember, when you submit claims, there are some requirements that you attach some documents, including the theater notes, the itemized invoice, and many others. When the quality of the scanned documents cannot be read, and remember we have undergone digital transformation, then it becomes a challenge for us to read your documents, and they are rejected. They are what I call scanty clinical or financial entries. You find that the discharge summary is very faint. Someone says or just writes a sentence without explaining the underlying treatment, and as such, our case management officers and the system will promptly reject it. I've said the issue of itemized invoice, which is non-itemized. The other reason is caused by providers. Sometimes we reject claims and you are required to rectify those claims and resubmit. And there's a 14 days window within which you can rectify those claims and resubmit in case of missing documents. And sometimes providers resubmit claims after the window period has expired. The other reason is late submission of claims. Healthcare providers have signed a contract to submit claims within a period of 7 days. If you submit later, then SHA will reject your claims. The other reason that leads to rejection is fraudulent or non-compliant claims. We have mismatches between what is claimed and what is recorded in the patient file. You are admitted for one disease. At the point of discharge, whatever you are being treated for does not align with the treatment plan that the healthcare provider did file. There's issues of hospital administration and record keeping issues. you will find dates. We have what we call dates mismatch. You find from the point of admission, the date you admitted, the date you went to the lab, the date you went to the theater, and discharges are at variances. They are not aligned. And it raises queries that it could be a case of fraud. I want to end it there, but what I want to encourage facilities. Some of the facilities that have undergone training, and we've seen, I know a facility in Thika that underwent claims training, and their rejection rate reduced by 98%. Those things that I've mentioned, when we sat down, took them through them, they came up with a quality checklist that they use before they resubmit they launch claims to SHA. They've been able to reduce rejections and ensure that they are promptly paid on time. Thank you.
All right, so let's take one more round of questions. And please keep it short and straight to the point. Only one question. We have a hard stop at exactly 4:30. So only one question. If you start asking the other me, I'll come and pick the mic from you, because we have so many people who have questions. So please, you can start, sir. And please keep it short and straight to the point. If a question has been answered, please don't ask it again.
Okay, thank you for giving me this opportunity. My name is Joshua Kibet on behalf of Hearing Loss Society of Kenya. And people with disability. I have not heard anything about package for disability, because as per the government says that people with disability are exempted. They should be treated free of charge up to level 4. So here, SHA, you're telling us you don't have any package for these persons. So will the government care for them, or it's SHA? Because some of them are suffering. So we have cases whereby when you go to the hospital, you're told that you're supposed to get that free medication, but it is opposite. So people with disability actually are suffering. So we need to understand whether it's the different government or SHA is different, because SHA was enacted with passed in by the law. Also, Personal Disability Act was passed by Parliament. So when you go there, we are supposed to be implemented. So, and then we have another challenge where, for example, people with hearing loss, we have only 2 hospitals with bearer machines, that is brain effort response audiometry. It's found in Kenyatta and then allowed in Kapsabet. So you see that all over the Kenya, we have children who get hearing loss. So for them to get the medication, they have to travel up to Kenyatta. So, and then we have very few specialists, ENT. What is SHA doing so that they increase number of the ENT in each county, so that these people can also have access to inclusive health, as you are doing it right now. So we have a challenge. We need clear information whether we have a package for PWD, person with disability, or not, so that actually when PW go to a visitor hospital, they know that whether they pay or not, or you have said Lipapole is there, but you have not talked about person with disability, which is very clear under the Constitution of Kenya. Thank you.
Thank you very much.
Can I talk while seated? Thank you. So my name is Thomas Jimbo, and I'm also from the Hearing Loss Society of Kenya. First, I would like to amplify what my brother Joshua has spoken about. Devices such as cochlear implants and hearing aids are far beyond the reach of many people with disability, who mostly come from the lower economic tier of the society. And we'll really appreciate it if SHA would, take it up. But because a majority of our concerns as people with hearing loss have already been mentioned by Joshua, I would just like to maybe add on to other issues that came up while my predecessors spoke. For example, there is the lady who spoke about infertility and how infertility affects women. I would also like to, echo that and ask that as you cover infertility in women, you can also look at infertility in men and what causes them and whatever causes that. Just a moment. Okay, you also mentioned, there's somebody who mentioned emergency services. And I'd like to ask whether SHA covers, emergency services such as, maybe ambulance, whether you are a police officer or the one on the other side, if, let's say, you get a gunshot or something like that. And also, when you talk of emergency services, what do you mean? I've mentioned maybe an accident, a car accident could be one of them. What else? Maybe if you've been bitten by a snake or something, is that one also, does it fall under that? I understand, I don't know whether anyone has talked about chronic diseases such as, maybe lifestyle diseases like heart disease, for example. And how does SHA incentivize its members to participate more in preventive measures such as keeping a healthy lifestyle so that you don't end up with a hefty bill when these people become immobile because they do not lead a healthy lifestyle. For example, when it comes to half marathon or, cycling competitions and all that, I would expect SHA to be at the front line, because when you build a culture of, embracing healthy lifestyles, then in the long term, we are preventing bigger bills with heart diseases and, such like things. Then lastly, somebody talked about the SHA testing, means testing tool. But I really think what we are all saying is that the means testing tool as is now is not working for us. And most people feel that those people who need the services the most, those who come from the lower economic tier of society, are being undercharged, and the super rich and upper middle income members of society are being undercharged. They may pay more, but still they're being undercharged. These ones may pay less, but they're still being overcharged. Thank you.
Good afternoon. My first question, is a compliment. And in May last year, SHA paid over 1 million for a relative of mine who needed to have heart surgery. I think it's good to give credit where it belongs, isn't it? Okay. My other question is, if a patient has had an operation at the beginning of the year, does SHA pay for another operation? Say you had surgery in January, and then in November, December, you need another operation. I just need some clarity if SHA does pay for it, or do they pay only once a year? My other question is about serious frustrations that patients go through when there is downtime. Patients are in a queue like all of us are now, and they are told that the SHA is, we have breakdown in IT or something like that. And you can read a lot of frustration And the worst of them is somebody who has come in and it's an emergency and they are being told they can't be registered, they can't receive care. I really want to hear from you what advice you give to the hospital staff during such downtimes. The last one, charges on retired staff. When one is in employment, their employer will comfortably pay for their share. Okay. But now when they are retired, should they continue being treated as somebody who is in employment? I'd really like to hear your feedback. Thank you.
Good evening, everyone. My name is Mary Gadhi. I have 3 questions. 1, what measures has SHA put in place to prevent corruption, delays, and poor service delivery so that Kenyans can truly trust the health systems? 2, how has SHA ensured that every young Kenyan, including the unemployed and those in informal jobs, can access affordable and quality health care without discrimination or financial struggle? The 3rd one, we hear of people saying that inpatient, the SHA can pay for them, but the outpatient, the SHA cannot afford to pay for them. Can you tell us why, and when we had NHIF, it didn't discriminate whether you are inpatient or outpatient? Then my final question, the last question, I would like a clarity on, I'm a mental health advocate, and SHA, it is true there is that in SHA there is something relating to mental health, but SHA does not cover the psychological diseases, disorders, those ones. It doesn't concern them. Why? And yet, the time we had NHIF, it didn't discriminate whether you have a disorder, whether you don't. It used to cover everything. Thank you.
All right, thank you. So I think we have 2 more, unless there's a hand I did not see. Okay. All right, please go ahead.
Good evening. My first question is about the payments from a provider perspective. Gilbert was talking about the rejection of claims, but there are also those that are approved. Like for my facility, for instance, we've had invoices approved for payment, but the payments have not been made since October of last year. We keep following up and they say they would be paid, but it's not forthcoming. Perhaps you could also speak about that. The second issue is about the benefits panel. They visited my facility today, and we have that conversation, and some of those tariffs that they are being offered for the public officers medical service fund, some of those tariffs are honestly ridiculous, because you find a procedure that would ordinarily cost 200,000, the maximum tariff being offered by SHA is 70,000. The cost of the procedure alone is not even half of what the SHA is providing as a tariff. Perhaps we'd want to look at it to see that whilst we offer services, we also want to remain in operation, so that we don't offer service and you are crippled. In one hand, the tariffs are low, on the other hand, you are not paying them in good time. And finally, on the question of system downtime, I think it's something that you really have to look at it. Sometimes I have to go through a hassle of a whole day just getting a pre-auth. I cannot start a treatment without that, because otherwise, if he does not pre-auth, I could treat a patient for free. I think it's something that on your end you need to really work on it so that it works at all times, because the patient would not understand a downtime at some point. Thank you.
Thank you for this opportunity. My name is James Luka Mabea. I come from Siaya County. I have one question to our social health age, that is SHA. And this question is in 3 formats. As our social insurer, how do you position yourself in relation to the theme of the discussion, considering that you provide services even to the entire part of the nation, in relation that do you know your customers? And how, I've heard you talk about fraudulence. How do you justify fraudulence in a hospital that you know very well a procedure was done? And perhaps it is the issue of perhaps legibility or legible writings. And from your own words, that a patient came in with a diagnosis perhaps of road traffic accident, but what led to that road traffic accident was hypoglycemia or stroke. And in the process of investigations and inquiry, the patient was found to be hypertensive, a diabetic, which led to the accident. So how do you justify fraudulence in such a scenario? Thirdly, it's about standards. In public sector and private sector, we all provide services. We all know tools that are used in service provision. For example, in maternity, a delivery has to be conducted using a pantograph, for example, discharge notes. These are standards across the country. So if those documents have been submitted and they are all well filled, how do you justify fraudulence? And in terms of standardization also, we all know the drugs from medical fraternity which are used, for example, in provision. Why can't you come up with a tool that is used across board so that for you to demystify the issue of fraudulence, for example, the drugs that are used in maternity, why can't you list them by adopting experts that these are drugs that are used in maternity? So for the work of the personnel, it's just a matter of ticking in plus the dosage, so that to reduce the issues that comes with rejection of claims and perhaps from your side issues of fraudulence. Thank you so much.
Hello everyone, my name is Obadia Oyaro, and I have one question and one request from the provider's perspective. Okay, I'll start the request. My request is if updates of the system can be communicated earlier so that the providers or the facility can be aware or know when and the time of the updates are being done. And another question is from the system downtime failure. At times you get a service needs to be done through pre-auth, and with pre-auth it has to transition to being finalized. So at times you get the pre-auth can take 2 to 3 days to be approved, and in circumstances you have to contact the help desk, but what to get from them, it's full of frustrations. Wanakuzungusha huku na huku tu. So what can you say about that? Thank you.
Good afternoon. My name is Justa Kajuju, young leader in Diabetes Kenya 2025-2027 International Diabetes Federation. My question is on type 1 diabetes. In Kenya, we have levels of hospitals, level 1, 2, 3, 4, 5, 6 in the private sector. My question is, SHA does up to level 3, and we still have people living with diabetes in that mostly has seen in these levels of facilities where we don't have special doctors or clinics for these patients, and they rely on insulin and other medical deliveries that we use to manage the condition. So my question is, how is the SHA as institution is able to manage, or rather to, take care of those patients? And number 2, my second question is, are we going to have different, policies coming to handle chronic disease rather than having a law that, takes care takes care for longevity but not for a short period of time, for the sustainability of these patients without, changing them from one regime to another, or rather one institution from NHIF, from SHA, we don't know the next will be what. So why can't we have a policy that, it's permanent to handle such kind of diseases, or rather of chronic diseases? Number 3, in case you want to change these packages, for instance, we have a cancer package that was amended, I think 2 months ago. So let's say we want to amend, or rather we have a petition, we want amendment on diabetes package. How are we going to support that when we know we don't have data? We don't have data to support these. How do you as an institution support, or rather budget for, patients that you don't have data for? So, and how are you going to address the disparities and the gaps that we can see in the SHA as institution? And also another question, or rather another concern is, didn't you not involve people at, when you were making this as a policy, or do you really need to go back to us again to involve us so that you can make the rightful adjustments that will sort all these gaps we can see in SHA's institution? And again, I would like to say it's working at some point, but you need to check on those things. Thank you.
All right, you guys, I'm losing trust in you, Sasa. Eh? You say one question and you ask 15,000. All right, any other question? Kabla nifungie mtu clarification. You okay? All right. Question, clarification, comment? Okay. All right. So I think we can answer those ones and then close the session from there. But thank you so much for all your questions and your concerns. Over to you, Gilbert and Julia.
Okay, thank you once again. We had Joshua Kibet talking on the persons living with disabilities. What I picked from you is a cover by government so that you can be treated almost without paying. And then hearing loss as well, followed by Thomas, who also reiterated on the hearing aids and treatment. So for the persons with disability, the defunct NHIF had some funding, which my colleague may speak about. But currently what is happening is, in the absence of anyone willing to pull together funds for people living with disabilities, they have not been left out. Because unless there is really something unique and special, then that should reach out to be brought out and be known. But should they require any of the services that the authority pays for, they can access. And it's the whole range that we presented. A person with disability may require inpatient admission. It will be paid for. They may require an MRI. It will be paid for. So what we can do is to look at these people living with disability, what the uniqueness of their health-seeking behavior and what exactly they need. And this is what can be packaged for them. And then it is tariffed and implemented. But we have not left out persons living with disability. They are covered. When it comes to hearing, the authority pays, is it 358,600 for cochlear implants. Now, the authority doesn't choose which implant the person has, because I hear they are special to the needs of the person affected. So we have not been silent. When you need a hearing aid, we come in at that level and we take care of that cost up to that 358,000. Now, the means testing, my colleague will answer. For the emergency services, we have taken healthcare providers who were activated. I just want to confirm that were activated for emergency services, so that when we say that emergency services are covered, and like I said, if you can remember, I said the first 24 hours, it is on the exchequer. And then the next, because they rely on the Constitution, which says access to healthcare, including emergency services. So the authority has listed out the services that are paid for when you have a need for emergency care. Conditions that are related to your heart behaving like it's failing, difficulty in breathing, you are undergoing, almost going into pulmonary arrest, major traumas. Somebody presents with major traumas, head injuries, road traffic accidents, severe wounds, multiple fractures. The burns, like now we had a very sad incident yesterday. Somebody presents with shock states, dehydration, hemorrhagic shocks and all that, septic shocks. Somebody is confused, they have altered levels of consciousness. You notice they're in distress when they are breathing. So these are things that fall under emergency. And yes, snake bites is also there, dog bites is also there, so that the emergency package has lifted out anti-rabies, anti-snake venom, it's also there. Somebody presents with chest pain and you don't know what's going on. So you don't know whether they are going into coronary syndrome or they have a pulmonary Ebola. You don't know what they are. So all that has been well packaged into the emergency package. And it takes care of that. The first 24 hours, then the continuing, you now have to be a member if SHA is undertaking the costs. The other question is the lady who gave credit to the support they received for their colleague or friend or relative, and indeed that is not segregative. What happened to that person is still happening and to others as well, because SHA is an equal payer. So your question was at the beginning of the year and at the end of the year, will it pay if it is a surgical procedure? Now, the departure of SHA from NHIF is, in NHIF, it followed the government financial year. So you are covered from July to June. So we would look at that and we would know that if you had a surgery in July and it is a specialized surgery which is covered once, then the next time you can only have it is after a year. If we pay for like 3 surgeries in minor, so we count them. If within that financial year you've accessed 3, when you go for the 4th one, the system will pick that out and highlight that you have exhausted. With the authority, it is a premium year. It is not a financial year, neither is it a calendar year. So we don't do January to December, we don't do July to June, we do your premium year. When did you first pay us? In March. So your cover will run from March to February next year. You pay in October, it will run from October to September next year. So it counts your year from the time you paid. So for this member, you can check with them, when did they first pay us? So you run the 12 months. And then you see, is this benefit they want to access? Does the authority undertake once or twice or thrice a year? Then that will answer your question. For the retirees, I didn't quite get this. Maybe if the employer was, okay, my colleague will answer that one. Thank you. Mary. Mary is asking the authority, the mikakati ya kukabili corruption. You can be sure the president also is suffering from this. So this is a country problem. We shall see what we can say. Then affordable care without struggle. Yes, that is why the Social Health Authority exists. If you look at the rates that we are paying for and asking for, it is really bordering on social health and affordable, and without, we were really trying so that you don't end up in catastrophes and you don't become poor because you're sick. So that is the essence that governs us. So Mary, that is what we do, albeit in the best way we can. Then you mentioned paying for outpatient and inpatient. SHA is paying for outpatient. When you go to a level 2 and 3 contracted facility, they do not charge you. So the government has provided that. You only need to know which one is it. There you will not be charged. When it comes to the higher ones, which do not do primary health care, it is assumed that probably you could be going for an outpatient specialized service, because 4, 5, and 6 offer them. And what did the authority do with this knowledge? They started with the lab tests that are required, especially for the chronic ailments. So that's where they come in when it comes to the higher levels for outpatient. So it is covered for SHA is paying for outpatient, we are saying, and also for inpatient. And even in a better way than the former NHIF was trying to do. Psychosocial disorders, these ones are covered. Remember, the authority does not profile illness. When you're registering, there's nowhere we'll ask you what conditions do you have. So we don't profile illness. And when someone has a psychosocial issue, a mental issue, when they go to hospital, the benefit package that applies there kicks in. If this person requires lab test and we pay for it, kicks in. Inpatient payments, it kicks in. So they are also covered. I think that would end. The benefits panel, there were questions from someone who either missed the name or they didn't say. My colleague will answer on the facility payments. The benefit panel, whoever visited your facility today is not the panel. There are not many. Then they're sitting somewhere waiting for the data. So I hope you spoke to the team. The team you saw were SHA doctors, and they are going round. If you do not, if the 70 can't work, I hope you put your voice there, because that's what the panel will sit down and look at. So we are going around trying to settle on a figure for the public officers. So when you see them, kindly contribute, let your voice be heard, let your inputs be taken. Fraudulence will be spoken for here. And the turnaround time. The diabetes type 1, there is no classification of illness, like I said, and any and every service that they may need is covered. But for the specialized services that are geared toward diabetes, we will appreciate to hear from the benefits tariffs that now diabetes we pay for like this, so that we undertake that. For now, it is taken care of as a medical condition, and it is paid for alongside the inpatient or outpatient, or whether it is lab medical care. It is not packaged as a condition on its own. It falls under the medical conditions. Having one organization, that one we can't say. The new government came with SHA. We don't know if another government will come with another thing. We cannot tell. Yes. Thank you.
Thank you, Julia. Allow me to respond to what some of our members have asked. I'll start with the issue of persons with disabilities. I want to confirm that indeed the national government pays for premiums for persons with disability. We have the Health Insurance Subsidy Program, that is acronymed HISPS, older persons and persons with severe disability. In the current financial year, they did sponsor in excess of 67,000 indigent households, and they do so every year. What needs to be done is for persons living with disability to approach the social protection officers or the community health promoters who will identify them for inclusion into the health insurance subsidy program. I know perhaps, as you correctly insinuated, that some people may not be aware of this. The Bible tells us that my people perish because of lack of sufficient knowledge. So we've put into place a robust communication plan to ensure that we demystify what SHA is administering. I'll come back to that later, but long and short, that is currently happening. Now, the other thing that was raised relates to ambulatory services. There was someone who wanted to know whether SHA provides for ambulatory services. Now, I want to assure you that the issue of ambulatory services is work in progress, and very soon it's going to be launched. It will provide for transportation of Kenyans that have been involved in road traffic accidents from the scene of accident. They'll be stabilized, treated, and transferred to the nearest empaneled and contracted healthcare provider. Secondly, it will also provide for transfers for Kenyans facing life-threatening ailments from lower-level care facilities to higher-level care facilities. Now, there's an issue Joshua raised on preventive promotive healthcare. We cannot talk of UHC attainment without preventive promotive wellness. And we have started in earnest. For your information, under the Primary Healthcare Fund, the level 2, level 3, and select level 4 facilities are under obligation to organize preventive promotive healthcare for our members who visit their facilities. I know it started in earnest. As we continue, you will see many engagement on wellness education, and we welcome your submissions on the same. In terms of the means testing tool, I hear your issue that the tool may not be accurate. I want to assure you that the SHIF Act provides that the Social Health Authority, the State Department Social Protection, the Ministry of Health, will periodically review the means testing tool. And I want to assure you that is work in progress. It's being reviewed for the sole purposes to enhance its accuracy. I also had your issue on system downtimes and the frustrations that our sister said. I want to assure you that SHA is working overdrive to ensure that the issue of system downtime is addressed. And we are working to ensure that even in event of a system downtime, we have a fallback position that ensures that there is the continuum of services so that members do not miss services. There is the issue of retirees that was raised by one of our colleagues. What is the way forward for these pensioners who've given their best life in service? And I'm to assure you that SHA onboards retirees. What needs to be done, they need to undergo the means testing to determine the premiums payable by them. Then they can be able to remit annual premiums, and they'll be able to access the entire scope of cover. Now, what measures have been put into place to ensure that all Kenyans can access services? Thank you, Mary Gadi, and to assure you that the government through SHA is working overdrive to ensure that no Kenyan is left behind. In my presentation, I did indicate we have what we call the safety net, whereby the national government has provided for the poor and vulnerable Kenyans, whom we refer to as indigents in SHA, whom the national government pays annual premiums for. It also pays for other Kenyans who are vulnerable. I've indicated orphans and vulnerable children, older persons and persons with severe disability. I've also informed you that the national government, through SHA, pays for adolescent mothers or teenage mothers. So that program is there, and it was put in law that the national government, county governments have a mandate to pay for this cohort of poor and vulnerable persons. There is the issue of payments, approved claims and delayed reimbursement that was asked by our brother. I hear you. I want to just update you that SHA pays claims that have been approved, and what we normally do is that claims are paid on the 14th of every month as guided by the principal ministry, and we also pay based on what you've submitted. In case there could be delays, and I hear you that you've not received payment, I'll kindly request you make a point of seeing us after this so that we can pick your issue and refer to the functional office, claims management. You can see me after the discussion. Now, in terms of do you know your customers, I want to assure you that indeed provider management, where my sister sits, has been conducting what is known as KYC across the 11,000 healthcare providers. I want to ask the providers attending this particular discussion, how many of you have been visited, including you who has been visited today? Yes, you can see. We do know our customers, and we do listen. We've captured where they are, their geospatial location, the kind of scope of cover they administer, and the contact person for those facilities. We periodically come back to update our records so we know our clients. Now, how do you justify fraud? I want to tell our brother that we have a robust artificial intelligence system that is able to detect upcoding, whereby you are treating for a procedure that is not reimbursed very well. You scale up that procedure so that you get higher payments. We have issues of unbundling, just to name but a few. The system is quite robust. It has gone modeling and the simulations, and its accuracy as we speak is in excess of 98%. I like what you said of standardization on the list of drugs based on the treatment plan. Indeed, there is a plan to ensure that even we have the pharmacy benefit package embedded in the SHA database in future. We take it positively, and is a thing that is being looked upon. There's the issue of system updates to be communicated to the healthcare providers. Periodically, SHA issues memos to the healthcare providers informing them of system updates. We hear you, and we are working overdrive to ensure that those updates reach you. A case in time was the update in the dialysis benefit package, where a memo was issued to all healthcare providers informing them on the changes that had been done to that particular benefit package. Now, delays in pre-authorization, allow me to say this. The turnaround time for pre-authorization at SHA is 24 hours. And for your information, nowadays, it is as little as 10 minutes if your documentation is correct, even 5 minutes. When you notice an issue of delay, that should signal that there is an issue with the request you put across, and it's imperative as a healthcare provider to check the database to see whether the claim has been rejected or you've been told to add some additional information. The issue of pre-authorization now is a thing. In the past we get very few complaints. So what I'd like to say, in the event you are witnessing such issues, bring it to our attention. Now, I want to talk something on the issue that has been raised what is SHA doing to ensure there's public awareness, public education and awareness, and I'm happy we have the communication manager here, but allow me to just share insights with your permission, Mr. Jacob. Now, SHA is doing a lot to ensure that we empower our members. I did indicate that the Holy Book tells us that our people perish because of lack of sufficient knowledge in the book of Hosea 4. Now, what is SHA doing? We are currently working closely with community health promoters. And these health promoters are in excess of 100,000 and they've been allocated 100 households. We've been sensitizing them on the registration processes, that is registration of members, declaration of dependents, the spouse and the children. We have sensitized them on proxy means testing to determine the premiums payable. They've been sensitized on the expanded scope of cover of the SHA benefit package, including what SHA reimburses for the three funds, that is the primary health care fund, the SHIF and the emergency chronic critical illness fund. The other thing that we are doing, we have a rapid result initiative. We are working closely with county government, conducting intensive registration and awareness drives across the counties. We are currently in Nairobi and the other counties, whereby our county managers have reached out to the county governments, and we want to salute the county governments. I'm happy to report that recently we had a robust drive in Makueni, and that particular county has onboarded indigents. Same case to Murang'a. There is an ongoing campaign in Lamu and many others. And these campaigns involve the chief and the assistant chief, the national government administrative officers, we have the village administrators, Nyumba Kumi. We work closely with religious leaders, organized community groups, and of course we attend the public barazas. The other thing we are doing is leveraging on technology. SHA is expanding digital platforms to improve awareness and accessibility. I'm very much aware that very soon my brother Jacob, Dr. Jacob, is about to launch something whereby he'll be engaging members of the public through the digital platform, and we'll have a fortnightly program whereby you'll be able to select the topic of your choice and you'll be able to invite a subject expert matters to demystify SHA. We are also working closely with other state actors, including healthcare providers and others, to sensitize members of the public. Allow me to pause there, and we can be able to respond to further questions. Over to you, Julia.
Let me finish by saying there's a nice question asked by, is it Mary, who challenged us that do we really use data when we are making, was it Mary making these decisions? Yeah. So I'll quickly just quote some data here that we have. The authority since October 2024, and these were last month's figures, I'm sure they have changed, has financed 1.08 million deliveries. Those are babies. A politician would clap because those are votes. So 1.08 million deliveries have been financed at a cost of 16.6 billion. We have unique cancer patients standing at 43,000 Kenyans, 661. We have also unique dialysis patients at 14,000 Kenyans, 819. Dialysis, only on dialysis. And from 2024, about 7.3 billion plus has been paid. So those are figures that informed. Now, when you look at the changes that we made, even those changes were informed by some data that we were seeing. So we use data a lot to make decisions. The reason government has now allocated 2 billion for level 2 and 3 deliveries. So government has seen the importance and using the data we've shared, they are now also financing level 2 and 3. So you go to a level 2 and 3 facility that is contracted for free maternity, you will be paid for at no cost. Another thing I would want to mention is that in our database, we noticed that 16% of the 40+ thousand Kenyans with cancer had exhausted their limits. So you can't tell where they are, you don't know what they're doing, you don't know if they're accessing care, you don't know if they've given up, they're just waiting, you can't tell. So that also informed. And over 3,000 of the 43,000 had went ahead and exhausted even the 150,000 that the government had added. So that data that was also used to inform the decisions and the reviews. In the renal care, over 80% of the 14,000 are undergoing the 2 sessions per week. And we are supporting at an average of 1.1 million per person per year. So what are we saying as we conclude is that indeed SHA is the backbone of health financing in Kenya, both in maternal, cancer care, renal, free delivery, and even the imaging services. No one does big business at this scale, but we are still hoping to do better. So let your requests reach the panel so that the panel can incorporate them and bring them forth for further financing. Thank you very much.
To add on what Julia said, at SHA we realize that data is the new oil. I want to invite you to visit our website. Our communication team did a fantastic job. They published the PHC report that had even the impact. Kindly create time to go to that particular website to see what we have been able to deploy there. And periodically we post reports there. So make it a point of logging in. Allow me to respond to Mary Gashie. She had asked a question that what is SHA and the national government put into place to slay the monster of fraud, wastage and abuse and corruption. Mary, I want to assure you that they have put into place a robust system. The first one being digital claims processing. We moved away from the manual claims processing to digitalization of claims processing and reimbursement. This has reduced manual handling that was prone to errors and fraud, and as such, we have an end-to-end visibility of claims that are being processed. We have automated adjudication to help flag fraud, wastage and abuse. The other thing we are doing is a unique beneficiary identification. Every person who has registered to SHA has been given a CR number, which is a client registry number that is unique. We also use biometrics when you're accessing services at healthcare providers for purposes of authentication. And the biometrics are very effective in arresting the issues of fraud through impersonation. The other thing that we are doing is through the provider empanelment and accreditation controls. We have a robust system that vets the facilities that are empaneled and contracted to SHA. As I did indicate earlier, there is an ongoing exercise that was done across the country to know the healthcare providers that are empaneled. Apart from that, you might have heard in the print and electronic media that a number of facilities have been flagged and some of them have been taken to court because they've been cited for issues to do with fraud. You remember the CS did indicate earlier this year in excess of 1,188 files were submitted to the Directorate of Criminal Investigation for purposes of carrying out investigation. We are also leveraging on technology. We realize that for us to make headway, we must rely on data analytics and fraud detection. And we have a robust fraud detection engine that has undergone machine learning and training, and it's able to arrest fraud in real time. Apart from that, we have internal and external controls. We have a robust audit department that periodically reviews the financial flows, they review claims integrity and the procurement process. There is the separation of roles and approved controls. Key functions such as claims processing, approvals, and payments are separated across different units to ensure that there is no issue of collusion or manipulation. We have provided for whistle-blowing and a complex mechanism. There is an email that is fraud@sha.go.ke where members of the public can write and inform SHA of healthcare facilities or practitioners that are involved in fraud, and there will be independent investigations to verify such cases. We also work in close collaboration with other state agencies that are given the mandate to undertake investigations, and as such, we have been able to arrest this monster of fraud, wastage, and abuse. But I want to state here, our purpose is not to fight fraud, but we want to encourage Kenyans to ensure that they have clear visibility on the benefit packages and the limits entitled to them. So whenever you seek healthcare services, please get to know how much you've been charged, get to have your invoice because it's your right. Above it all, take time to log into our social media sites. That is the SHA website. We are available at Twitter, we are available at Threads, and many others. With those very many remarks, I want to end it there and submit. Thank you once again for the opportunity, and on behalf of the management of SHA, we say Asante Sana, and we look forward to many more events. This is testament that SHA is ready and willing to engage the public, even as we march to mark our second anniversary, which is October 2026. Thanks and God bless.
Fantastic. Let's give them a very, very big round of applause. They did not run away. They did not shy away from all your questions. So we say special thank you, Gilbert Osoro, who's the Assistant Director, Registration and Compliance from SHA, that is Social Health Authority, and also Julia Awino, who's the Assistant Director, Provider Management, again from SHA. Thank you so much, lady and gentlemen, for your time and for engaging with us and for answering all our questions and our concerns, you know, with no fear. Okay, so we really appreciate you, and also appreciate yourselves, you know, for sticking with it for the 2 days that we've been here for the Nation Health Summit 2026. So give yourselves a very big round of applause, and especially for staying up until the end. So, you know, most of the times the last day, most people just tend to leave earlier on. So thank you for staying with us, and allow me to just do a very quick vote of thanks before we disperse. Distinguished guests, esteemed panelists, partners, stakeholders, ladies and gentlemen, as we come to the close of this impactful Healthcare Excellence Summit, we extend our sincere gratitude to each and every one of you for your presence, for your participation and invaluable contribution to today's conversations and yesterday's as well. To our keynote speakers and panelists, thank you for generously sharing your expertise, your experiences, and insights on some of the most pressing issues shaping the future of healthcare. From governance and policy to digital transformation, AI, data analytics, innovation, and equitable access to care, your perspectives have not only informed us, but also challenged us to think boldly about the future of healthcare in our region. We extend also a special appreciation to the Nation Media Commercial team for organizing this important summit and creating a platform that brings together leaders, policymakers, healthcare professionals, innovators, and stakeholders committed to advancing healthcare excellence. To our sponsors, partners, exhibitors, and supporting organizations, thank you. Thank you for your collaboration and commitment towards strengthening healthcare systems and improving patient outcomes. Your support has made the summit possible. And to all the participants and attendees, once again, let's give ourselves a very big round of applause. We say thank you for your engagement, thoughtful contributions, and active participation throughout the sessions. The conversations held here for the 2 days are an important reminder that healthcare transformation requires collective effort, shared responsibility, and continuous collaboration. As we leave the summit, may the discussions and ideas shared here translate into meaningful action stronger partnerships, smarter systems, and more inclusive healthcare solutions for our communities. The future of healthcare depends not only on innovation and technology, but also on leadership, compassion, collaboration, and the commitment to place people at the center of care. Thank you once again for being part of this important journey. Safe travels, continued success, and we look forward to future engagements together. My name is Winnie Lubembe, honored to have been your MC and moderator for the 2 days, and I hope to see you soon, if not on the next Health Summit, maybe in another forum. God bless. Thank you so much for your time. And please, if you have not scanned the QR code for your feedback,